So basically, so I am the regional primary care cancer lead for LIN 3, which is Waterloo, Wellington. So I work out of Grand River Cancer Center in this role, my leadership role. In my role as, there's some of my colleagues here that actually know what I do for a living, and will probably tell you that I don't know what I'm talking about. And so in my clinical role, I work as a GP oncologist.
Is that okay?
Yeah, perfect.
If you can pin that on, and then I'll find you a clicker.
Okay, great. I prefer the clicker than that, but so I worked as a GP oncologist. So I trained in family medicine. I went to Newfoundland for my residency. I went to Labrador. I lived in Goose Bay for a long time. Then I met my husband, who was living in England. It was a bit of a commute, to be honest. So I moved back to Cambridge, which is where I grew up, and I was actually a candy striper at the hospital there. And now I work there, and it's really awful when your cancer survivors come in and they remember you falling asleep in church, which I still do. But I go to Kitchener now, so none of them see me. Okay, so this is basically what the gist of this conversation is going to be about. I'm happy to take questions on our way through, but there's a lot of material to cover. And I'm not known for keeping things short, so a lot of the stuff we have touched on already, which is helpful. So basically, what we want to talk about here is to look at survivorship. What exactly, first of all, I like to say what's not on there is what is survivorship, because that is different. Some people will take offense. Some of your cancer survivors will take offense to the term survivor. One of my colleagues who is a cancer survivor will try and educate people up every time they say, oh, so you're a survivor, being kind, but she doesn't like the term, to be honest. She feels she's raised Catholic, so she thinks it jinxes her. So anyway, so I want to talk about why it's important to you in primary care and why it's going to become increasingly important. We want to talk about survivorship care plans so that you know what you're going to be introduced to when you see people that are coming back to you. And then we're going to talk about what exactly I do. In Cambridge, I work, like I said, I work as a GP oncologist, and we actually follow the patients to 5 years. And so I'll tell you what I basically do every day. And it's not all that difficult, obviously. Like my colleagues who work there will tell you, if I can do it, anybody can do it. And then we're going to talk about what to look for. So, and provide you with some resources at the end. Oh yeah, the clicker still hasn't come, has it? Okay. And then this is a thing that you've seen, and again, the point of this slide is really to show you that we recognize that Cancer Care Ontario, or Cancer Care Ontario, has recognized and added primary care in across the journey. We know that whilst all of you will probably not say, yeah, I recognize I'm there for prevention, I know I do the screening, and I know I work up the diagnosis, but yeah, the treatment phase we drop off. And then in the recovery and end of life care, people have varying degrees of interest and number of patients that they have back. But to be honest, the studies have shown that patients are seeing you just as often, if not more often, than their oncologist during the treatment phase. So you are seeing them there too, which brings us back to Anita's talk there about the palliative care approach. So they are seeing you. We don't know what they're seeing you about, it's just on billing codes, but we know that they're visiting you throughout the stage. But today we're gonna, I always forget when I put these little fancy things in that I put them there. So today we're obviously focusing on recovery and survivorship. So what exactly is survivorship? And this is where we talk about the fact that there are multiple things. So people will say that, people will often say that being disease-free does not mean being free of your disease. Some people will say that they're survivors from the instant they're diagnosed, because once you're diagnosed, you're a cancer survivor for any length of time that you've got, whether it is a terminal cancer or not. Other people will say this, but for the purposes of our conversation today, we're going to take the Institute of Medicine's definition of survivorship, which is also Cancer Care Ontario's definition of survivorship, and that is basically that a cancer survivor is someone that has finished their primary treatments. So they will have finished their chemotherapy and their radiation treatments, and then they may still be on some form of anti-estrogen therapy, but that's when they're considered to be ready for discharge back to primary care. So now we're going to talk about, so we've talked a little bit about what it is. So we're going to talk about why primary care plays such an important role in survivorship after treatment. And it really, the thing that we created had multiple slides to say this, but at the end of the day, the bottom line is there's no capacity in the cancer centers for caring for the tsunami. We use that word a lot, for the tsunami of cancer survivors. what is that term where they say you're a victim of your own successes? So basically, there are more and more and more people living with the diagnosis of cancer in the past. And so all of these people require ongoing support because, as we'll see throughout this presentation, that indeed they do have they have an increased risk of other cancers, etc. So they still need adequate care. And if you want, and in primary care, it's in our best interest to take care of our survivors or our recovered cancer patients. Because if we want to expedite the care for those that are newly diagnosed, which is really, of all the patients that I see, they say the scariest phase is when they don't have a plan. They don't really know. They still have the inkling of a hope that maybe this is all some nightmare that's not true. And that's a very difficult phase. So expediting that phase is really important. So to get them out of the cancer centers and back home with you guys, where you actually, I would argue, do a better job of taking care of the patients, and that's coming from me who actually does do survivorship care. I think you do a better job, and I'll tell you why as we go through the presentation. So this is basically, this document, you can get the free PDF form online. That's what I was doing, reading this last night. Is actually pretty interesting. I've always wanted to read it, and and then finally got around to reading parts of it because it's very lengthy. But basically it is a landmark report so the Institute of Medicine put out, and it was to examine, so what they recognized was that they're in the States, you imagine, we've got X number of survivors there that you just saw, and large numbers coming forward. And in the States it's even bigger, they have a bigger population. So what they wanted to do, the purpose of this landmark, they put a bunch of people together and they said, well, this is a new, we've got care for people with heart failure, we got programs in place for people with diabetes, we've got programs in place we need a program in place for the special needs that cancer survivors have, because they do have special needs. And so these are the 10 recommendations that they have made, that came out of this big, this report, and then the report is long because there's like 70 odd pages on each of those bullets. So we're not going into all of that, but I put this down because you'll see it a couple of times throughout, and it's just to show you how at Cancer Care Ontario that they are looking at instituting some of these recommendations that have come out of this. So this is something that. So basically, why you and I don't know. Is anybody? When I first started talking to folks in the Cambridge area about the fact that cancer survivors are probably coming your way, most were a bit anxious about that. That they may not feel that they've got I don't know what it was, but most people would say, well, I'm petrified about missing missing something, and that person has an early death because I missed something. Well, this randomized control trial is an excellent way of assuaging your fears or anxieties, because so basically what they did was the objective of the study was to assess the effective time to diagnosis and quality of life after transferring responsibility of follow-up care from breast cancer from hospital to general practice. So it's a randomized control trial, 18 months of follow-up, 296 women that were being discharged from district hospitals, breast cancer survivors. And the outcome measure was the first presentation of symptoms and confirmation of recurrence. And basically there was a day's difference between the two groups. And what they did discover, so what they did discover was most of those were interval findings. What I always tell people is, if you have, my cancer survivors, if you have any symptoms, don't wait for your next appointment. Don't, have your persistent cough and hemoptysis and say, well, I'm seeing the doctor about my cancer in another 3 months, so I'll wait. People don't do that, right? They don't have the decency to wait, I always tell them. And the fact of the matter is that most of these people that presented with symptoms, and they presented to you. They didn't present to me. Now in Cambridge, quite often they present to you, and then you talk to me because we expedite things. But at the end of the day, you're already doing the care, so you don't need to be nervous about it. You're already doing it, and you're doing it right, because again, they came to oncology care in 21 days. There was like 21 and 22 days between symptom and being put back into the system. So then there's more reasons as to why I think that we are better at doing this. And for all those reasons that you went into family medicine. Well, I'm hoping maybe you went into it for the money and you're now discovering that that was wrong. But really, you know the patients well. You know their background. When I see patients, like I just had a lady this week who I've never met her husband. She's 80. I can't speak her language. She doesn't speak mine. Well, I could speak a little bit, but I would probably just be telling her I can slap her in the head in my underpants, because that's all I learned in Portuguese at school, because I went to a highly Portuguese school. But it probably wouldn't come in handy when I'm trying to find out, do a mini mental status on her, because I think she's got a glucose of 36 because she's not taking her insulin, but she's telling me she is. I've never met her son. I have no idea what her family situation is like. You guys know all that, and you don't have to take the time to find out. Okay, so basically moving further, so this is one of my colleagues who is a cancer survivor, loves this picture, and I do too, because as the cancer survivor, you're that guy in the middle. And to be honest, nobody's comfortable with the transition, right? The oncologists are quite nervous about handing off their patients, thinking that you're going to miss stuff, which other studies have proven you don't. And then in primary care, just like, geez, I don't know, just keep them there, because then I know that they're safe. And the poor old patient is stuck in the middle, thinking like, this is my life, right? So we're going to look at, so again, now we're going to take another step down. So we want to, basically one of the recommendations that came out of that plan was that, out of that landmark study, was that we need to provide a care plan for survivorship. And so this is a care plan that needs to be, that then Cancer Care Ontario said, yep, that's a good idea. And we should have, every LHIN should have one of these. So we all went to the drawing board. This is before I came along. So if you in Waterloo, Wellington don't like the survivorship care plan that's there, well, it wasn't my doing. Anyway, basically all of them, so every LHIN has a survivorship care plan. I tried to get some images of ours and of yours, Jan, but I couldn't. My skills aren't that good at PowerPoint. So I've got some examples in a second. But what is it? Basically, it's a tool, a communication tool. So instead of just getting the letter of discharge, which we all know from specialists, some are great and very helpful and very prescriptive, and others are completely useless. Here you go, here's Jane back. Send her back, there's problems. So basically, what it's supposed to have, the tool is supposed to have, give you lots of information about who they are, what they've been through, and it does give you some information that hopefully as we go on you'll discover gives you some ideas about prognosticating for yourself, like which Jane Doe should I be more concerned about, and really be looking for a metastatic process versus who's less likely to come back with problems. I should also mention, again, to assuage your fears, that no studies have actually shown that early diagnosis of metastatic disease decreases mortality. It does if you get, that is going to change over time, because as you heard, they're doing radiation on oligo, whatever they're called, metastases. And we can do, if you are lucky enough to find a single liver lesion, then they can do hepatectomies now, and perchance, and there's a 35 to 40% chance of long-term survival or 5-year survival after that. But nobody presents with a symptomatic single metastasis. So when you find someone who's got a metastatic disease, you can decrease their morbidity, but you're not going to decrease their mortality. So you haven't done anything harmful by missing it by a week. I've had a ton of people, and it's embarrassing to admit, but I had one, but it happens because they don't have symptoms and then they do. So for example, I had a lung cancer patient. He was actually a friend of mine, a friend of the family, came in to see me for his 3-month follow-up. We know that eventually it's going to recur. Had absolutely no symptoms when I went through the history and physical that I would do. I ask always about focal, you'll see in a minute, I always ask about focal neurological findings, and had none. And then 2 days later, no word to lie, 2 days later he had stroke-like symptoms and has brain mets. But you're not going to pick that up, right? Unless they're showing signs and symptoms, you're not going to pick it up. And you can't beat yourself up over it. Of course, you will go back in your chart, just like I did, to say, was there anything that was an indicator? So this is what a survivorship care plan looks like. I know that you really can't see that, but here's a couple more images. different survivorship care plans. But basically, it just gives you an overview of who they are. For example, the breast cancer patient, we have one for breast and we have one for colorectal. And those are the survivors we're going to be talking about today, because frankly, they are the vast majority of the survivors, and they are the ones that are going to be transitioned back. There was also a slide that I took out because, for interest of time, you're not getting all cancer survivors back, because not all people are still surviving their cancer. So your pancreatic cancers are probably not coming back to you. They will be seeing you while they're seeing us, but they are not going to have a lot of longevity. We have made some inroads, before when you were diagnosed, you had 3 months, maybe 6 months. Some people are getting as long as 18 months if they were fit and young when they started and they get heavy dose chemotherapy. But those aren't the people you're going to be seeing. The vast majority of people that you're going to be seeing are breast and colorectal, and you're already seeing your prostate cancer patients. So it does give you some valuable information about, for example, the breast cancer patients, whether they're ER/PR positive, HER2 positive, and all those things give you some idea regarding prognostication. So who's appropriate? And again, we kind of alluded to this. So it's the people that basically have completed their treatments, and then they are felt to be ready to be discharged. The bullets down there are, some people go from specialist to in ours, I know they go from specialist, they follow up the nurse practitioner to make sure that everybody there's no side effects from their medications, no lingering things that we need to control or get or fix up, and then they're ready to go home, and then they would get the survivorship care plan. And the survivorship care plan is supposed to be talked about with the patient and sent to you guys, so that she or he also know what the plan is moving forward, so that they can take some ownership too about the fact that I know I have to have an annual mammogram, I know I'm supposed to see my doctor every 6 months. Oops, did I go backwards there? Okay. Okay, let's see where I am. You're getting on. It's going okay. It's going all over the place. Anyway, so I will just, since I have no thing to know how to go back or forward. So basically, the people who are coming back to you are the breast and colorectal cancers, and they are going to be, so your breast patients are going to be the well breast cancer patients who've been diagnosed with stage 1, 2, or 3 disease. They will have completed their active therapy. They will have been determined to be free of any recurrent disease at the time of discharge. It'll be determined that they have nothing that requires oncology supervision, and that they have an identified primary care practitioner. Right? There's no sense in discharging someone that doesn't exist. And then I believe the next picture that you just saw that had all the bells and whistles there. Let me see if I can go back. Escape? Well, that's the trick. Someone knows. Oh yeah, let's see. Where am I supposed to be, though? That is the question. Oh. All right. Aha. Here we go. So, I didn't stick my tongue out. Okay. Okay, so these are the colorectal cancer patients. So does everybody know what... I think sometimes when we do these survivorship care talks, people take for granted that people in primary care know what their cancer patients have been through. Do you have an idea of what a breast cancer patient has been through? You probably know, okay, chemotherapy and. So basically, for your colorectal cancer patients, these are going to be your low risk. They will have completed treatment. They're stage 1 to 3, and again, I think I have the fancy thing. So stage 1, so they're is based on the TMN characteristics. So basically, they're smaller tumors. They may have up to stage 3. They may have had 1 to 3 lymph nodes involved. So of course, again, on your survivorship care plan, it's going to give you some idea. The ones that have the higher the staging, the more likely it is that they're going to recur. 5-year survival rates for colorectal cancer patients is pretty good. It's 65%. That's for all comers. Those with stage 1 disease, so they'll be a T1 lesion with potential up to T1 to 2, which is just size of the tumor, with no lymph nodes involved. They've got 93% chance of 5-year recovery. And the other thing is, if you live 5 years in cancer, generally, if you've done well for 5 years, you're going to do well for another 5 years. That's the idea. Breast cancer patients, that goes out the window, because frankly, if you do well for 5 years, you could do well for another 5 years, you could do well for another 10 years, and then you may get a recurrence of your original cancer. And again, that's more common with the ER/PR positive population. So then in stage 2A and B, with 2A it's a larger tumor with no lymph nodes there, 85%. 2B, again, larger tumor, no lymph nodes, 72%. Stage 3, they're a smaller tumor size but have a lymph node involved, 83% chance they'll be still with us at 5 years. Stage 3B is a larger tumor with a lymph node, and then stage 3 has more lymph nodes involved, and theirs for 3B is 64%, and for 3C is 44%. Again, this is where it's documented on your chart. So that's why those things, again, you don't have to remember these things, you just have to, I like to keep it simple, stupid. And so basically the higher they move up that stage, the more likely it is that they're going to recur. And stage 4, which is obviously metastatic disease, 8%. Those are not the people that are being discharged back to you. So the goals of follow-up care, now I'm going to get all my, see, there's my fancy stuff now. So these are the goals of follow-up care. Jen, are you keeping an eye on time for me? Because there's no clock and my thing keeps going off. So basically you want, and this is why I think that we as primary care do a better job of following, and I say we, and I can't lump myself in with you guys. I don't do a very good job at a lot of the stuff that I'm going to be telling you you should be doing, but you guys are doing it already, I know. So to provide support and counseling for them. Again, in my clinic, we don't have time for a lot of support and counseling, but we do have our social workers who do, so thank you. She's here today, one of them. And this is where I think, again, to promote a healthy lifestyle, this is, you guys are doing this all the time with all your patients, I'm sure. And so this is a population that you're going to continue to do that with. And again, and screening, I would say, fits in there too. And again, that is more your purview than it is the oncologists. And I'll talk about that in a sec. And then, of course, to provide timely care for those in whom metastatic disease develops. And then to manage the lasting effects from cancer and its treatments. So this is one of the studies I like to show that I read, and it changed something that I do, because now I will comment when I see my cancer survivors. Basically, this study showed that cancer survivors well, a lot of people are not being screened for cancer as they should be as to the recommendations, the Ontario recommendations. But you would think that someone with cancer they are at higher risk of developing other cancers, and you think that because they're in the cancer system, they should be getting screened for cancer. Surely they're up to date, but the vast majority of them are not up to date with their screening. So when I read this study, the first thing I do now as a GP oncologist that's seeing my patients in 5-year follow-up, I always ask them, so have you had your other bits checked? You know, just because you've had one cancer doesn't mean that you can't have another, unfortunately. And I will say in my letter back to the primary care practitioner that they are up to date with their screening for PAP, and they're going to talk to you about their FOBT because they still got it lying around at home and haven't done it yet. So, but the fact of the matter is, I think you guys make better people to follow up because this is on your radar. The other thing that's on your radar is vaccinations. I also have a thing that we should be sending our patients before we make them immunosuppressed to see you, because I know nothing about herpes zoster, but a lot of my patients get it. Perhaps if I'd sent them to you to have a conversation about, listen, we're just about to wipe out your immune system here, maybe we should make sure you're up to date with all your vaccinations. And that does not cross the mind of oncologists, I'll tell you that now. Okay, so we can't talk about, so there's no safe amount of alcohol if you're going to talk about cancer. So I know that we all, well, maybe I'm letting a little bit personal here. We all love our red wine, right? It's not just me. And whilst it may be beneficial for increasing your HDL cholesterol and giving you a better, that's what I stick to anyway, it is not going to be helpful for your cancer risk. And again, for women who have had breast cancer, we know that breast cancer, there is an increased association between alcohol intake and breast cancer. So why wouldn't we take the opportunity in a highly motivated person, hopefully, to tell them what they can do to avoid recurrences. There isn't any data that says you're more at risk of a recurrence. But I think sometimes, again, I know that if I was jumping out of an airplane, I probably would take a parachute because that likely would increase my odds of survival, although there was someone that jumped out of an airplane and it didn't work and they survived, but I wouldn't want to take my chances. But at the end of the day, we know that it increases the risk of you getting a breast cancer, so why would it not increase the risk of you getting a recurrence? Randomized control trials have not shown that, nor is it shown that that decreasing your weight or eating healthy decreases it, but common sense is common sense, in my opinion. Again, smoking cessation, this is a great opportunity to talk to people about, all those times you've said, listen, this could happen to you, you could get cancer, and now they have. What a great opportunity to talk about let's decrease the likelihood of this happening again. Again, weight management, we already know, so studies have shown that women who are obese and develop breast cancer don't do as well. They have their overall survival and cancer-specific survival is decreased. So again, why would you? There must be something about obesity that increases your risk of breast cancer. So why by being obese post breast cancer? Why getting rid of some of that excess weight wouldn't be a good idea? I don't know. So looking at interventions, they have done studies that look at interventions that have targeted diet, physical activity, and they have shown that, again, this can improve quality of life. It decreases post-cancer fatigue, which is very common. It increases fitness levels. It increases physical function, and it decreases treatment-related side effects. So again, perfect opportunity to take, hopefully, a highly motivated person and get them moving. Same thing with exercise. There hasn't been any randomized control trial that says exercise is going to decrease your likelihood of recurrence. But again, it's going to make you feel better. You're going to get less of the psychosocial issues associated with living with cancer, and it's a healthy way of dealing with the stress of post-cancer life. This is handy because we've already spoken about this. So the ESAS score, this is something I would suggest. So your cancer patients are very familiar with this. Every time they come into the clinic, they're expected to fill out an ESAS, and it is very helpful, I must say, because again, in a busy doctor's office, instead of saying, "Hey, how are you doing?" This is the study that proves its usefulness. So instead of like my McMaster training told me to do, where I just ask open-ended questions and say, "Mary, how are you doing?" A lot of times Mary will say, "I'm fine." And meanwhile, if you gave her an ESAS, there's a high proportion of those patients that don't even tell you about highly symptomatic and highly problematic and highly distressing symptoms. So they're not going to volunteer it. Now some of the Marys I know, and one of them's your patient, will volunteer everything. And I dated her son, and there was a good reason we broke up. But there are other people that it actually keeps it down a little bit, because you can focus on, listen, Mary, you've identified that your pain is 10 out of 10. It also helps you in some ways, and Anita I went to a conference on this, and if they've got 10 out of 10 for a lot of things, generally they're not 10 out of 10 for a lot of things. That's always flags me as this person depressed. You guys have better scoring tools for depression, but that's the one I've got. And then again, as Anita was alluding to, once you have, so you're going to use the ESAS score with your patients to find out what their symptoms are. Not all of the ones that are that your survivors have are documented on there, but once you do find some symptoms, then you say, well, now what? As Anita said, there's not enough of her to go around, but there is this handy resource that's available for download. It's in every form possible. You can find it online. You can get hard copies of it, but basically takes you through, and it is very helpful. I have found with people with dyspnea, for example, it walks you through what opiate dose, if they're opiate naive or not naive, and what dose you use, and how you titrate it, and how you calculate it, etc. So they're quite helpful. Okay, so cancer-related fatigue. So this is the vast majority of people who have cancer will tell you that they're fatigued. I think the vast majority of people in North America would tell you that they're fatigued, but there's actually something to it. What causes the fatigue in cancer patients, we don't know. There's a whole host of things, but again, no randomized control trial has shown what the exact cause of cancer fatigue. We know that it is that there's multiple things, and some of them are listed on here that can cause it. What I would suggest is, just like everything else in medicine, if you decide to prescribe CBT and exercise, then you could generally heal a lot more people if we could actually get CBT, cognitive behavioral therapy, and if we could get people to exercise, we would probably have a lot fewer visits. And these are two of the strategies that are actually effective for cancer, that have been have improved cancer-related fatigue, or have been proven to. And again, I'm not going to spend a lot of time on cancer-related fatigue, but this is a great little video. Mike Evans, has anyone heard of Doc Mike Evans? He's on YouTube. He has all sorts of things, how to do your FOBT. He talks about the PSA or not to PSA. He talks about HPV or not to HPV. And this is him talking about cancer fatigue. And he does talk about things, and it is hard when you say to a patient that is, so for example, you're not going to be seeing these ones as cancer survivors, but for me, who's seeing a terminally, person who's got a PPS score of 60, and you're saying, well, you got to get out and exercise. You know, it's hard to convince them, but this video helps convince them that this may be what they need to do to actually improve their symptoms. Again, this is where I think, so the vast majority of people will breast cancer patients and colorectal cancer patients are dealing with do have psychosocial issues. It's not usually long-standing. So the vast majority of people, of women and men who are diagnosed with colorectal or breast cancer, have symptoms of depression at the time of diagnosis and when they initiate treatment, and those generally decline over time and do improve. But a big time of fear and concern is around the transition time, because again, it's letting go of the specialty care where they think that they all know everything, and then now I'm in the great unknown, and those are times where anxieties are at their greatest. This is so everybody has heard about cancer brain or chemo brain or chemo fog. It's got a whole pile of other names. So again, this is another thing that cancer and chemotherapy does to people, and we don't totally understand, but it is real. I like to tell you about this twin study that I learned about. Again, it's not a huge multi-center randomized control trial, but I think it's very helpful to talk to patients about. So they took two identical twins, both female. One twin had breast cancer, the other one hadn't. So one twin had been through chemotherapy, radiation, and surgery, and the other twin obviously had not. And what they did was they did, I think it's a functional MRI, but basically what they did, and the lady that told us about this study, she made us do it. Basically they flashed a letter or a number on the screen, and then they showed another letter or number, and you had to tell them what the number before was. Then they did it again, and you had to tell them what the number or letter was 2 numbers before. And then they did it again, and you had to do it 3 numbers before. And we all got progressively worse in the audience, and that's what's expected, right? And basically they did the same study to the twins. And at the end they said to the twins, how do you think you did? Well, the one that had not been through chemotherapy said, that was tough. It got progressively tougher. I think I did all right, probably got more mistakes at the end. And the second twin said, that was incredibly difficult. I think I got them all wrong. I don't know. They did equally well. When they looked at the functional MRI, the woman who had had the chemotherapy, her brain lit up. And the lady who hadn't had the chemotherapy used a significant portion of brain, same areas, but not as much. So what that tells me, or what I like to tell patients, is you're going to be able, and this is the truth of the matter, you are going to be able to go back and do what you needed to do before, but you're going to take a lot more brain power to do it, and that's going to be mentally exhausting. So I think I like to tell them that, and it does improve over time, and you will be able to go back and do your job. The vast majority of people are able to return to work, but you're going to feel more tired at the end of the day. So now we're going to talk about the guidelines, because we in primary care like guidelines. Tells us what to do, when to do it, and that's great. And there's all sorts of stuff out there and available. Southwest region here has created these blue notes and pink notes. I was supposed to get copies of them today to show you, and I don't. But they are available online because I downloaded them to find out. And they do, even the pink notes have an online module that you can take that will take you at a much better way than I'm going to do today. Will take you through both pink notes are for breast cancer and blue notes are for colorectal cancer. They didn't choose brown for whatever reason.
Another conversation we can have later, 'cause I voted.
Yeah, oh Gaia. Okay, so basically every follow-up visit should include these things. Oops, I knew I'd go one too far. Oh, no, look, see? Anyway, okay, so basically you're going to do a history and physical, and I will just basically walk you through. This is for breast, obviously in pink it's breast. We're going to go through breast now. So the idea is, everywhere's a little bit different. In our center, we've chosen to just go with every 6 months we see patients. for the first in the first year, they get a mammogram. About a year after they probably will have had it, but that's something you'll get on your survivorship care plan. When did they have their mammogram? You're going to do an annual mammogram for that woman, and then you will and you'll see them every 6 months. So the one visit you'll do just a visit, history, physical, and psychosocial screening, and then you'll go over the mammogram in the next one and order the mammogram on an annual basis. Also, I'm just going to actually move to this. So studies have shown that they did studies both with colorectal and breast cancer patients of intensive doing blood work, doing for tumor markers for breast cancer, and none of those studies showed improved morbidity or didn't decrease mortality. So now they're saying, and people generally present with symptoms of their metastatic disease. So that's why you don't have to do routine blood work, etc. Now you might be incorporating this into your what formerly was called, but we don't call the annual health exam anymore, and so you might be doing blood work, but it's not for the purposes of their breast cancer. So this is where we'll stop for a little bit. So basically, what you want to talk about is, so I will just tell you what I do. I say, oh, Mrs. Jones, how are you today? I can see from your ESAS you're good. And my nurse has already been in to see you, and she tells me that you're feeling great. There's been no new diagnoses through the family doctor's office. No new medications. No that I need to know of. No. Okay, great. Any troubles with? So now we're going to ask you all those. I know you said no to everything, but I'm going to ask you all those questions anyway, just to be sure. Because you'll be surprised. I had one lady who we said any problems. The nurse had been in there, and I was like, I specifically asked her any new lumps or bumps, and I asked her specifically that one first, which I usually start at the head and work my way down, because when I walked into the room, I noticed her vercalced node. And she had not noticed this massive lump above her. So when you ask for lumps and bumps, they're thinking lumps and bumps. And I say lumps or bumps anywhere that I should know about. Sometimes that works its way. You get people showing you some acne or something like that. But anyway, I'd rather know. So basically I say, have you had any headaches, changes in vision? And then I always stop and say, like double vision or blindness. Your eyes are allowed to get old, but because you'll always have his patient Mary that'll tell you about how her new prescription, etc. And then I ask about, so I'm looking specifically for focal neurological findings, right? Then I'll ask about any trouble with your breathing, any feelings of shortness of breath, any feelings of any cough, and I'm sure you would have told me if you coughed up blood. Those are all things I want to know about, by the way, if they happen in between. Again, you're allowed to get sick, you're allowed to have a cold, but if that cough persists and persists, then it's good to let someone know about it. Again, you're going to look for the signs. So here we're looking for both signs and symptoms of potential metastatic disease, but we're also looking for side effects of the medication. Lymphedema, for example, can happen. It peaks at about 14 months, but it can happen out of the blue 3 years later. So never a heavy arm. If it happens 3 years later, then you want to look at potential other diagnoses like a blood clot, but you also want to think about could this be lymphedema and manage it. Always ask about medication adherence. In these, we know that with most medications, that people don't take them. 20 to 50% of women on a medication that that has a significant decrease in their risk. I think Tamoxifen was quoted as a 50% risk reduction or something crazy like that, aren't taking their medications. Now the good news is one study did show that even if they take it a little bit, but they don't take it every day, they're probably getting some benefit. But frankly, if I'm going to take a medication that's going to give me a significant decreased risk of my cancer recurrence, I'd like to think that I would take it every day, but I probably wouldn't as well. Like everybody else, I'd forget sometimes. But again, lots of these women are not taking it, and the vast majority of them quit it because of bone and joint discomfort, and that's something we could do something about. Return of periods, especially because sometimes people will get chemotherapy-induced periods, and you want to know if they get their period back, and because that has sometimes people are thought to be in menopause and will go on an aromatase inhibitor, and those women who are perimenopausal should be on tamoxifen, not an aromatase inhibitor. The tamoxifen blocks the estrogen, but an aromatase inhibitor, what it can sometimes do, this is what I tell my patients: if you've got active ovaries and we say the body recognizes, oh, there's no estrogen coming through, we need more estrogen, the ovaries are like, whoa, get get that estrogen pumping out. So you have to make sure that they're absolutely. Your ovaries probably don't talk like that. I always tell my patients as well, but that's the way I think about it. So that's why women who are perimenopausal cannot be on an aromatase inhibitor because it defeats the purpose. New skin, the other thing I always ask about is any changes in the breasts, any skin discoloration, stippling. Well, I don't ask them these questions, but I'll say anything, discoloration, is the nipple poking in when it never has before? Does it look like cellulite, or do you know what that looks like? Because I do. Or does it look like an orange peel on your breast? Because those are all things that suggest new disease, obviously. And then GI complaints, again, this would be more in your BRCA1 or BRCA2 population where you're looking for ovarian as well. And then new or persistent joint pain, again, that is, you're looking there for bone pain that could represent metastasis, or also it's another flag as to what might be causing the discontinuation of their aromatase inhibitor. And peripheral neuropathy, that could be a long-standing effect of their chemotherapy. So more on that later. Again, you're going to be asking about these things, so you may be talking to them about chemo brain. One thing that we don't do a very good job at, I don't think anybody does, but hopefully you guys are better, talking about sexual function and fertility in some, because we are getting younger women. Those women tend to be more high risk, so they're probably not coming back to you guys. Oh, I got to speak even faster than I already am. But it's a big issue, and it's always the people that I don't want to know that they're having sex that volunteer that information. But, anyway, okay, so how long are they going to be on hormonal treatment? So basically now we know tamoxifen has been studied to death, and we have the end of the 10-year study. Women on tamoxifen are on it for 10 years now. 10 years is better than 5. Ongoing studies are looking at, is 10 years of aromatase inhibitor better than 5, or should these women that finish their tamoxifen go on aromatase inhibitor for 5 years after? Those studies are yet to be complete, but 10 years is better than 5 with tamoxifen. So after 10 years, so when you see your patients with respect to the aromatase inhibitor, I would say to you, at the 5-year mark, send them back to the oncologist, because at this point in time, things are changing, and in a few years' time, we'll have the results of that study. And I think most oncologists at this point, at least our oncologist is saying, looking back specifically at what their risk of recurrence is likely to be, and if they're at higher risk, they will err on the side of, well, why don't we, if you're tolerating it well, you haven't got, your bones aren't crumbling, you haven't got osteonecrosis of the jaw, then let's carry on with the aromatase inhibitor, but send them back. So this, again, you will have the slides. Basically, you're going to be seeing a lot of the women will get symptoms of depression. Just beware if they're on tamoxifen, there are a lot of drug interactions. And again, this is in the pink notes. I've stolen this directly from them, and it's there. So again, I don't need to talk at length, but just know that there are a heck of a lot of them. And in Ireland, we do send out the drug interactions to avoid. Again, common side effects of both. You'll get symptoms of menopause, commonly managed with Effexor. Some women are afraid that that'll decrease the efficacy of their medications, decreasing the likelihood of a recurrence. But again, it's one of those things, maybe it does a little bit, but if your life is so miserable that you're not taking the medication, probably the Effexor is just fine. Dose of 37.5 to start with. If that works, great. If it doesn't, go up to 75. Beyond 75 doesn't really make a big difference. Again, with the aromatase inhibitors, it does not with the tamoxifen. Tamoxifen is bone sparing, but the aromatase inhibitors, there is an increased risk, and again, of developing osteoporosis or significant decrease. The bone mineral density test should have been done at the baseline, and that should be on your survivorship care plan. You pay attention to what it says. If they're osteopenic, then you repeat it a year. Again, I don't need to tell a room full of primary care practitioners how to manage osteoporosis. But when it comes back to you, just know with the aromatase inhibitor, this is what I do. If it tells you that they are at, that they are, in that intermediate where we never know what to do, up-regulate, so if you look at, okay, they've been on this aromatase inhibitor for a year, they are 55, and they have another 4 years of this aromatase inhibitor, then I'm going to err on the side of their bones are going to get progressively weaker. and then I will initiate treatment sooner than I would in the lady that's at the tail end and she's 85 and she's still at intermediate risk. So again, I don't need to tell a room of primary care practitioners about how to manage osteoporosis. And again, that's why I think you're better at doing this care. So the blue notes, let's go through this quickly. So same thing with colorectal cancer. It's exactly the same thing I say to them, same history and physical. The follow-up guidelines are every 6 months you meet with them. And then you do a CEA every 6 months, and then CT chest, abdomen, and pelvis, especially chest. Chest is optional. Rectal, we always, pointing, just in case you don't know where the rectum is. That's where it is, or was if they've lost it. But so basically with rectal, there's the risk, there's a lot more risk that it will go to the lungs, and so and less so with colon cancer, but never say never with cancer. So you can do a chest x-ray and CT abdo-pelvis for your colons, but basically in ours we do chest abdo-pelvis. And then colonoscopy, again, your surgeon usually does about a year after the surgery, and then you go by what they see, and they take care of that for us. And the CEA, I'll just tell you, the CEA you do require one of these forms that can be downloaded so they don't get charged for it. And you'll see it's a bit confusing because, to be honest, sometimes you'll see it'll say for treatment monitoring of the patient and for this and for follow-up of stage 2 or stage 3 colorectal cancer. So find that one and then make that one have your stamp on that one. And so CEA is actually, the CT scan will pick up the CEA is a tumor marker, and I always forget what it stands for, chorionic embryonic antigen or something like that. And in some people, if we all had a preoperative CEA, it would be great, because if their CEA is really high, then they have their surgery goes really low, and then they get their chemo goes even lower maybe, then if we start to see a rise in the CEA, then it makes you scratch your head and think, okay, I gotta look for metastases here. I gotta look for disease. I gotta look, even if that CT scan was fine 6 months ago, I gotta check again. CEA is more sensitive than the CAT scan is at picking up the disease. So again, you're doing all the same things with colorectal. Obviously, you're going to ask specifically about bowel or bladder habits, and I always say my things always read no blood coming out of any orifice. I always ask the patient, any blood coming out of any orifice, and then they look at me strange. I'm like, blood shouldn't be coming out anywhere. I don't want to know if you got the occasional nosebleed, but. And then basically you're going to want to go through the things that radiation can cause, the things that chemotherapy can cause, and then the obvious life of living with an ostomy if indeed they haven't been able to have a reversal. And again, the blue notes actually tells you if this is present. Here's some ideas. I will tell you that radiation-induced burns are very difficult to treat and sometimes extremely painful. It's very common. It's very common for them, especially with the low anterior resections, to get significant chronic diarrhea. And again, the treatments are not specific to cancer survivors, but you use your Imodium and you try and then sometimes we use Questran, which is you're familiar with for decreasing triglycerides, I believe, or increasing HDL. But basically, it helps bind. You're basically trying to bind them up. Again, very common in this population for them to get peripheral neuropathy. One of the little things I like to tell about that is with peripheral neuropathy, sometimes people will complain it shouldn't be worsening. They've had their chemo. Most people will get chemotherapy-induced neuropathy. They will get at the time of their diagnosis, so they'll reach into the fridge and they'll get a zap. I always like to warn them that it happens to their lips too, so that's a big shock when we tell them about their fingers and toes and then they go outside and their lips are on fire. Or they feel like they can't swallow when they finally get that drink of cold water out of the fridge. But that tends to go away. There are some people in whom it persists. Oh, I got 5 more minutes, perfect. There are some people in whom it persists. It can take up to 18 months for that to resolve, but what you're left with at 18 months, you're likely left with. You can use the usual things for the usual suspects for peripheral neuropathy, such as gabapentin or pregabalin. Pregabalin is slightly better than and the only reason we used gabapentin before was because you had to use it so you could get the pregabalin paid for those on ODB. But either one, as long as it's tolerated. But at the end of the day, I often tell patients it doesn't help with the numbness. It helps with painful neuropathies. So don't be, if your patient has numbness, a lot of times people think that I'm going to take this medication, it's going to improve my neuropathy. It's not going to help the nerves regrow. No, it just helps with the pain or the burning. So if you don't have the pain or burning, you just have like, it feels like my feet are dead, it doesn't help with that. So don't put someone on a 3-time-a-day medication for something it's not going to do. But if they have horrific pain, then by all means put them on it. The vast majority of these people, though, if it is worsening, it's diabetes. So keep that under better control. Despite the fact that I will have many, many arguments with many of my patients that it is not the ongoing effects of the chemotherapy that's causing their worsening peripheral neuropathy, and their blood sugar of 20 is not good enough. Talk to your family doctor. And again, the other thing is I'm just trying to go through these things because these things are all there. They're in the blue notes that tell you exactly what to do about them. So they're just to be an FYI. These are common complaints, things to maybe look for, ask about. But one of the other things I would say in, oh, hang on, it's left me. These are the one of my colleagues who helped create this documentation. This is her overall 3 things to remember. That using the ESAS tool is going to be extremely helpful. You're not going to miss things, especially from the psychosocial perspective. And it does decrease the time you spend. The symptom management tool is excellent. Again, you don't have to have all this crammed in your brain. You don't have to lose sleep over it. It's all there, and it's very how-to. Get the pink notes and the blue notes. They are very helpful for follow-up. You can even get Main Pro accredited things for the pink notes online. You can do it from the comfort of your own home. I got them. They were pretty easy. And then as for resources, this is a patient resource. It just tells them the things that they should be looking for and presenting with. So again, all the same things you're going to ask them about. Do you have a cough? Do you have persistent cough? Do you have any bleeding? Do you have weight loss that you can't explain? Etc. And tells them what to expect from you. So it tells them too, at 1 year you can expect 1 to 3 years you'll get your CAT scan. After 3 years, the likelihood of breast cancer recurrence is locally is highest in the first 2 years. If a woman has had a mastectomy, the likelihood, and she has a recurrence at the site, the likelihood is highly significant that is highly likely that she has distant metastases as well. It's kind of the same as having a distant metastases if you have a chest wall recurrence. And then this is that website that Anita was telling you about. So this is the Cancer Care Ontario's website. If you go into the PC resources button, and then it has all of these things that we've talked about today. It has ESAS. It has the screening guideline. It has the surveillance guidelines. So it'll tell you if you wanted to follow up the colorectal cancer patients. The breast ones are still in a work in progress, I believe. The other thing is each of us here in Southwest, I know they do have a website for primary care, and in KW in Lynn too, in the Waterloo region, we have Cancer Care number 4. I always do that, for primarycare.ca or .com. It gets you the same place. And that we have all of these resources on there, and you do have the survivorship care plan that we have discovered. Sorry about that, it always takes way longer than I think it's going to take, and I'm happy to take any questions, and I don't need my lunch just yet because I had an apple, so I can stick around.